Welcome with me, Professor Geoff Richards, Executive Director of the AO Foundation and President of Termis Global, and Manuela Ernst. She's a project leader at the AO Research Institute here in Davos. And they will give us a workshop about digitalized aftercare in orthopaedics. As we heard from Florian Geppert, there were huge improvements in orthopaedics. But how about the aftercare? And Geoff and Manuela will give us an insight into a new implant system that was developed at the AO Research Institute here in Davos, our host here today. So the floor is yours. Welcome, Geoff and Manuela.
Thank you. So first of all, it's very high honor to be working with Davos Digital on their first online event. We're really happy to be involved with this and hoping to help as much as we can afterwards. You will have seen on stream 2 a talk from Professor Chesmiakis, who leads a world-leading institute on asthma and allergy research and infectious diseases. We are the other medical research institute here in Davos. You've seen some great videos showing what we do in education to surgeons around the world. And now I will give a short introduction to the history of AO, and then Manuela will go into the details of our AO fracture monitor. So Manuela and I work as a team. Everything works as a team. It's the best way forward. So in the late 1950s, if somebody had an upper leg fracture, a femur fracture, or a lower leg fracture, a tibial fracture, they were put into traction or put into a full body cast. This really was not a very good treatment of the actual fractures, and 40% of the lower leg fractures and 60% of the upper leg fractures would never be able to work again. They'd be permanently disabled. So a group of medical surgeons who met at the Swiss Army decided this is not the way forward. We want to move forward and start a better operative technique. So the whole basis of this is to go into an operation and following principles that they started. And they trained the surgeons by bringing them to Davos. They were not allowed to use this technique unless they trained here in Davos. Now we train all over the world, as you'll see later. And the principles are fracture reduction to get the anatomy of the actual bone as it should be. Then early and active mobilization. This is the best treatment in nearly any disease. Move fast and keep loading. The more you sit, the more you are locked that way, the less chance you have of recovering. Stability in the fracture healing, and that goes according to where it is, the fracture. And also a very important area, preservation of the blood supply. So taking care of the actual soft tissues when you operate. So in 2018, we celebrated 60 years of the AO Foundation. And at that time, we commissioned Winterthur to do a study to look at the effect of the AO Foundation on treatment in the world. And they looked at basically 3 fractures: the upper leg, the femur, the lower leg, the tibia, and the radius, so the hand. And these are the most common fractures. They looked at 17 high-income countries who actually kept records and worked out from these the amount of life years gained for people. And it's over 855 billion francs. That's about the same in dollars that the AO has saved in just these 3 fractures around the world. So when you look at the over 70 population, it's also a great saving. It's over 69 billion francs and 73 million life years that have been gained from the AO. And this is by teaching in the first 50 to 60 years over 500,000 surgeons and using the surgeons to actually teach. And in recent years, teaching around 50,000 surgeons around the world how to operate. So having the work is good, but you need evidence-based, not eminence-based. Before the AO, everything was eminence-based. The higher up you were, the more you could say, but it wasn't based on evidence. So they knew they needed research. So they set up the Research Institute here in Davos. In this picture, you can see our clinician there from Leuven, that is Anne Sermon, working with an engineer from the ETH Switzerland, that is Ladina Fleury. These work together, and this is on actual osteoporosis and cementing bones to help retain implants. We work together as a team of engineers, biologists, material scientists, veterinarians, medical fellows, and many, many students. So unlike a university, we work on a clinical problem, just project-based. We do not work by department. And we don't work on our own, we work with people all over the world. And with this, I'm going to pass over on the AO fracture monitor to Manuela, and then I'll be back at the summary. Manuela.
Thank you, Geoff. So if we speak about digitalization, we are all aware how omnipresent such digital gadgets have become in the past years. We see, for example, in health monitoring, there's hardly anyone exercising anymore without tracking his or her performance. 20 years ago, there was mainly only top athletes really recording their heart rate and so on. And as we've just heard before in the keynote speak of Professor Gebhardt, digital technology has also made its way into the operation room with a wide range of available tools, for example, for preoperative planning and also some sophisticated navigation solutions. But unfortunately, this ends quite quickly as soon as the patient leaves the OR. And this is really a pity because there's really a lot of unused potential. And at least in a research setting, nowadays this potential is starting to being explored. This can be, for example, by instrumented implants such as prostheses or that record in vivo forces or implant stresses, or also some instrumented insoles to monitor weight-bearing activities. Unfortunately, this is at the moment still all in a research setting, and none of these solutions have so far made their way into clinical routine application as a medical device. We are currently trying to change this with the so-called AO fracture monitor, an active implantable medical device that is developed here in the AO Research Institute. And the purpose of this device is to monitor implant load to assess fracture healing. Now, if we first have a quick look at how assessment of bone healing is done at the moment, this is still mainly based on X-ray technology, and of course X-rays are a very important diagnostic tool for many medical applications, but it's just not really suitable for the assessment of fracture healing, unfortunately. So if you look at this series of X-rays here that were taken on a monthly basis, you probably see that it's really hard to detect any changes between the different images. But this is not just the case for us lay people, but also often surgeons struggle to make a valid conclusion from that. And besides, of course, because of the ionizing radiation of X-rays, these images should only be taken at a few time points in the rehabilitation cycle. So in between these images, we're always for several weeks, we're pretty much blinded and we have no clue what is actually happening there. Now, if we look at fracture fixation hardware, what is its main function? It's to bridge the fracture, to give stability, to restore the bone's function. But once healing starts, actually the bone gradually takes over its function again, and under physiological weight bearing, the weight on the fixation hardware is becoming less and less. What does this mean? There's actually a direct correlation between the implant load and the mechanical properties of the healing bone. So if we could somehow deliver this information on the healing, on the implant load, we could get an objective measure for fracture healing assessment, we could provide these values continuously and X-ray free. So this is how the fracture monitor that we're developing looks like. It's a small implantable device that can be attached via 2 screws to conventional bone plates. So it's a generic approach, which gives you high flexibility in selection of your implant and also on the exact location where you want to place your device. What happens if you mount it directly after the implantation, it starts recording each loading event under physiological weight bearing and transmits then this data forward to the surgeon. So if you look at how this data gets in the end to the physician, we have on the left our implant that once per day synchronizes with the smartphone of the patient. From there, with our dedicated app, the data is forwarded to a cloud server, and the surgeon can then access all his patient's data at any time he wants from remote to track the progression of fracture healing. So to have a look quickly at how this data might look like, I would like to share you quickly on screen to see our web app, which is at the moment still under construction. Let's see. Anyway, here, I hope you can see this now. So basically, if you log in as a surgeon, you have here on the left list of all your patients that you can switch to. You have in the middle now displayed our, let me reload quickly, our main implant load diagram that is used for assessment of bone healing. For example, here you see a graph how we would expect the curve to look like in a normal healing case without any complications. So for example, if the surgeon logs in here after 4 weeks, he sees that the curve is already dropping quite a bit, indicating that the bone healing has already initiated, the bone is consolidating. And with this information, the surgeon can adapt the treatment plan, the further treatment plan, individually to his patients. You can diagnose this quite early and thereby steer further weight bearing and also what activities are allowed, how fast the patient can go back to work, and so on individually. On the right, you also have some other information, general information on your device, like battery status, when the data was synchronized, and so on. If we look at one other graph here, for example, this patient, you see a different curve here. The implant load, which is here normalized to the maximum value that has been measured over the whole period. You see that it stays on a very high level for these 8-9 weeks, mostly above 90%, which indicates that there might be something wrong with the healing, there might be some complication. And again, the surgeon can then adapt the further treatment plan. He can already plan some additional therapies like maybe shockwave therapy, ultrasound, and so on, to try to bring this bone back to the healing path. And the huge potential here is that we can diagnose such things much, much earlier than with current methods, where, for example, a non-union is only diagnosed after 6 to 9 months. So if we can shorten this period of time and react earlier, we save a lot of pain for the patient and, of course, also a lot of healthcare costs. The nice thing about our continuous monitoring approach is that we can extract actually much more information than just this one graph that I showed you so far out of our data. So for example, here we have on the lower edge still the average values, average implant load that was recorded. But we also have like maximum values. So if you have some very high loading events that could be beneficial or maybe not so beneficial, you can track this as well. And if you click on a single day, for example, you see a histogram of all the events during that day and according to their intensity. So we believe that this is a very important point in our system. And I go back now to our main presentation. That we can deliver with time when we learn more about it, much more information than just this healing. Like I said here, we can get some activity patterns from the patient, but we can also maybe monitor the status of the implant to detect any implant bending or even estimate the risk of implant failure. And with that, I would like to conclude here and give back to Geoff.
Okay, so that was a really nice presentation there from Manuela. So we can try and summarize this. This is an active implantable digital medical device, moving on from x-rays, which obviously would never get approved nowadays. Taking a photograph of somebody that may give them cancer would not get through any monitoring case now. So this monitors autonomously all the time, continual fracture monitoring, and over 6 months. So it gives a lot of information for the doctor, for the patient, for the researchers. It gives an early detection of healing disturbances. So something that may last normally 180 days, you will see the problem after 40 days, and the doctor can intervene and save a lot of costs for the hospital. It minimizes x-rays and, of course, the associated problems and physical examination. So you can actually get the data from a person through the telephone going to the hospital, or even from an old age care home going from there to the hospital. So you don't need an ambulance and people taking them in. So this is a lot of cost savings. So the other side of that, of course, is if you think of the part that Sarah mentioned in a talk before of the location problems in Pakistan, as long as there's a telephone line, you could get this information direct to the doctor. So this will work very good in rural areas, as Sarah mentioned in a lovely talk earlier. So the next thing that it's good, it will generate a large amount of big data. This will help us better understand, monitor, improve, and regulate what is going on. And it also will, one second, sorry. It also will help for possible digital measure of evidence-based education, so we can monitor how people are learning all the time, and also individual patient-specific rehabilitation. This means we will be able to tailor healings according to if it's a sports person, a more sedentary person, and so on. And you'll also be able to see, is the patient compliant? Because the patient could come back after 3 months and say, it's not healing and I've done everything you've told me. But actually with this, you'll be able to see were they listening or were they just sitting and watching rugby on the television. So with that, actually, I would like to say thank you. And both Manuela and I are ready for any questions.
Thank you very, very much, Geoff and Manuela. Was really exciting. Thank you very, very much. Also, I don't want to have a broken leg, arm whatsoever. However, does your system allow that X-ray examination is totally replaced?
No, shall I take that one?
Yeah.
So no X-rays you will need at the beginning to make sure you're happy with how you've done your reduction and your actual operation. And I'd recommend, at least once we've confirmed this is working very well, at least one X-ray either towards the end or right at the end. And especially when you think of countries like America, where there are insurance issues all the time, you definitely will need an X-ray at the end to show, hey, look, this has healed, and yes, I did it right. So it will reduce the amount of X-rays.
Yeah, I need to add something on that.
Yes, very good. What I have another question for you is like, you know, this is obviously a really great innovation. And is this system, this monitoring already on the market? Is it already ready for the market?
No, it's not available on the market yet. What we've done is we've already done some 2 small clinical trials on an not implanted but X-body versions and prototypes. So we have some clinical data with the concept, but the actual registrational trial to approve the product as a medical device will hopefully start later this year, but towards the end of this year. And then with this study, hopefully we can get all the evidence that is needed to get approval for this product.
So with an external fixator, if you have a complicated fracture or you have an infection or areas like this, you have an external fixator outside your body and you're generally in the hospital when this is going on. So we've made some trials there. So the sensor hasn't been put inside the body, but is still measuring the load in the actual implant.
Very, very, very interesting. So you do have, I guess you have already a patent on this one. So you will make a lot of money out of it. How is this going to happen?
AO is a not-for-profit foundation. We spend around 100 million every year. We educate surgeons all over the world. We're not there for making money, but of course, we will license the patent to an industry, and with the license fees, we can put that back into research and innovation and so on. So we're not there as a profit-making company. We're there to help the world.
But the license fees, then that's then all goes to the foundation, to the AO Foundation for education purposes, etc., etc.
Well, for innovation and research and moving forward to help patients all over the world.
Very good. So thank you so much for this super interesting talk. And also I am missing this time the countdown timer. I see now the countdown timer, starts. It was really super interesting presentation. And again, what I think is very important for us, we joined forces this time for the first Davos Digital Forum Health Edition. And we couldn't have done that without the help of the AO Foundation. And we are very, very happy that we are still able to be here. And we are all looking forward for new ventures with the AO Foundation and Davos Digital Forum. So look, they are showing us where we are. And this is, you see, there's a lot of snow today in Davos. And having said that, I think, again, thank you very, very much, Geoff and Manuela. And please stay with us for the next workshop with Bejal Yoshi at 11:50.
Thanks a lot. Bye.